And together, we will move mountains. And if they don't hear our message, then we'll just do it over and over and over and over 1,000 times again for you.
And I'll rise up, I'll rise like the day, I'll rise up in spite of the end. I will rise, we will rise, we will rise, we will rise up.
Hello, my name is Michelle Zabel, and I'm an assistant dean at the University of Maryland School of Social Work and the proud director of the Institute for Innovation and Implementation. So this year of working virtually has necessitated some really creative approaches to conferences. For us, we've spread the Training Institute workshops over the last 9 months, hosting just a few workshops each month. And I want to thank you for joining in these discussions and participating each month. This summer, we're continuing the Training Institutes in a way that will allow you to take us wherever you go. And I am hopeful that you are able to take a break and get away safely. We're going to be recording our summer workshops and releasing them each month so you can watch them anytime during the month that works for you. These workshops are going to be on a wide range of topics, all focused around strengthening your skills as you support children, youth, and families. A quick note, some presentation reference information and graphics that are embedded within the presentations may not be fully explained within the audio, but all of the presentations are accessible to download, as well as the resources and handouts that correspond to each workshop, and I encourage you to do that. Thank you for listening to the audio recordings of our summer workshops for Training Institutes Live. While you're enjoying these summer months and workshops, we'll be planning and working towards future Training Institutes when hopefully we can all see each other in person. Take care, enjoy your summer. Thanks.
Hello, welcome to Youth Suicide Prevention Strategies. My name is Laurel Omland. I'm the director of the Child, Adolescent, and Family Unit at the Department of Mental Health. And I use she, her pronouns, and I will have Alison introduce herself next.
Hello, I'm Alison Krompf. I use she, her pronouns. I'm the Director of Quality and Accountability for the Department of Mental Health.
Hi, I'm Barri Faucett. I use she, her pronouns, and I'm the Director of Prevent Suicide West Virginia. So here are the objectives that we're hoping to cover today. If this were live, we would want to be engaging with you, our audience, and doing some small group activities, a full group report out. But instead, we wanted to introduce you to the concept of head, heart, and feet. So as you go with us through this workshop, we want you to think about what you've heard. We want you to think about what you like, and we want you to think about what you'll take away and bring back to your own state in your own work. So keep this in mind, maybe jot some thoughts down as we go through this today. And we're looking forward to this conversation. So first, we really did want to talk about language. We know language is important when talking about suicide. It plays a key role in reducing stigma. We hear from people with lived experience, they've told us that the way we speak about suicide, it can be healing or it can be harmful. And so please consider the language below or the language that's shown here. And encourage others to shift their use of language. We want to use terms like died by suicide or death by suicide or suicide attempt, rather than some of the other ones that are in that avoid column. I actually like this chart too because it provides the why behind that language choice. So the one other thing I wanted to just give note to, we're not going to show any video clips, but for those who have had the opportunity to hear Kevin Hines share his story or seen his film, The Ripple Effect, like me, you've probably been really struck by the power of his words and his ability to take his lived experience from a suicide attempt and really spread hope and healing and connection. And so that's, I think, an important part for us to be hearing and contributing to. So if you aren't familiar with Kevin and his story or his activism to change lives and save lives, his website is a great place to start, and that's kevinhinesstory.com. So we did want to start today. We're going to give you a couple of perspectives from two different states, one from Vermont, where I'm from, and Alison, and the other from West Virginia, where Barri's from. But first, we wanted to start with a national lens. to give some context to what we are working on in our respective states. So there was a strong recognition that suicide is a serious public health problem for individuals, for families, and for their communities, and that despite the pain and the loss and the suffering that individuals and families and communities experience, there's also tremendous stigma. There's shame and silence, and that can create barriers to people accessing the essential care and support that they need. And that led to a recognition that there needed to be a national public health approach. And that became our national strategy for suicide prevention. So initially, the strategy was released in 2001. It was updated in 2012, and through a collaboration between the U.S. Surgeon General and the National Action Alliance for Suicide Prevention. This was really a call to action outlining a unified approach across our country to suicide prevention. And so listed here are the 4 strategies that are part of that national strategy. Each of these has their own goals and objectives. So there are a total of 13 goals and 60 objectives. And the intent here is to really promote wellness, increase protection, reduce risk, identify effective treatment. And it's woven throughout with themes around public messaging, using integrated approaches, and reducing lethal means. We really want to ensure that people are aware that there are state and federal resources that can support suicide prevention efforts, that these efforts should be shaped by the voices of people with lived experience, that there's a recognition that suicide prevention efforts must engage all parts of our communities. It's not just up to one sector, but really it's everyone can contribute to this effort. There's also a strong focus in this new updated strategy around the importance of data collection and improving our data collection, and then using that information to share it more broadly to help people understand suicide, which populations might be more at risk, and what works. So it does highlight that need to communicate that there are effective interventions and resources that exist. So we're going to talk about some of those today. It is important to note too that since this national strategy was established, the suicide prevention efforts and programs have grown significantly across our country. And those are supported by some key structures like the Garrett Lee Smith Memorial Act, the National Suicide Prevention Lifeline, its partnership with the Veterans Crisis Line, and the Suicide Prevention Resource Center. So if you aren't familiar with any of those resources, we'll be talking about a few of them today. We also encourage you to continue to explore them on your own and then share them with others as well. So while much work has been happening and has been guided by this national strategy, it's clear that suicide continues to be a public health concern. As you can see in this graphic here, suicide is the second leading cause of death among people ages from age 10 up through 34. This data represents information from the Centers for Disease Control and Prevention, their leading causes of death and injury, information that's available publicly on their website. And this, again, we're going to get into some of the data sources that can really be useful for us as we're communicating with others about this topic. So to dive into some of those, there are some resources that are available nationally, and there are also some to be aware of that you might be able to access within your own state. I do want to share and just fully disclose that in my role in Vermont, I don't necessarily directly use these data sources, but I work in collaboration with those people who do and provide that analysis and then help us in our roles within the Department of Mental Health think about policy and resource direction and all of that. So given that, I want to provide a high-level overview of these sources, and I want to encourage you to either explore them or connect with your counterparts in your state health department or state prevention resource centers who might be familiar with what's available and where analyses could be found. So this first slide highlights some of the sources for data on suicide death. The Centers for Disease Control and Prevention is a great resource for us. It has several different components of information. One is the National Violent Death Reporting System, and that collects data on violent death. And that comes from Office of the Chief Medical Examiner. And it has information that includes circumstances related to death by suicide that can be informative. There's also the WHISPERS, which is the web-based inquiry statistics query and reporting system. And that's a fairly user-friendly interactive online database. And it provides both fatal and non-fatal injury, violent death, and cost of injury data. And then there's also the Syndrolic Surveillance system that comes out of the CDC. It's a collaboration with the CDC and state and local health departments. And that looks at encounter data from emergency departments and other urgent care settings, and it can help detect emerging public health concerns. And there is some information within that we can look at suicidal concerns, people coming to emergency departments, and with suicide-related visits. So that can be some helpful information to access as well. And then within your own state, state health departments hold vital statistics data, and that could be useful to look at suicide death rates. There are also different fatality review teams. There are child fatality review teams or domestic violence fatality review teams. And information from those teams could be aggregated and could also be useful to inform systems work and the development of prevention strategies. So those are some connections that might be resources for you if you have a need to continue to gather data around suicide and suicidal behaviors. So this next slide identifies sources for data on suicide risk factors. This is not all-inclusive. You might have other sources in your own state or country, but we wanted to highlight these and hope that it might help you identify others. Again, if this were live, we'd invite you to share some of your known resources. So the first one is the Youth Risk Behavior Survey, which many of you might already be familiar with, but this is a survey that's used to monitor health risk behaviors among youth. And it's conducted every 2 years among middle and high school age students. And the results for each state are available through the Centers for Disease Control and Prevention, or your local health department might also have some of these reports available for you to access. There's also the Suicide Prevention Lifeline, as well as Crisis Text Line. Those both allow us to look at data related to people contacting those, and it can help us see increase in help-seeking behavior. Sometimes you might be able to see your state-specific information. There's also the TREVOR project. I'm going to talk a little bit more about that in a couple of slides because it's a really important resource related to lesbian, gay, bisexual, transgender, and questioning youth. So we'll dive into that in a little bit more in a bit. And then state information, you might be able to access some hospital discharge data. So this data includes hospitalizations and emergency department visits among state residents. It can allow you to look more deeply at some of the presentations for youth who show up in emergency departments for mental health related concerns. And so you can use ICD-10 codes and look at suicide attempts, suicidal ideation, intentional self-harm, or intentional poisoning as some examples. And then related to that last one, the regional poison centers can also be helpful resources to look at intentional self-poisoning, which can be an indicator of concern for your state as well. And then lastly, I know many states, including Vermont, we use the Child and Adolescent Needs and Strengths tool, and that can provide a lens around risk and protective factors for youth and their caregivers. There are other sources, the National Survey of Children's Health, that can give you some perspective around mental health needs and strengths as well. So these are just some of the examples that we wanted to pass on. So of course, the value of data is around communication. There's information that we can glean from the data that we want to make sure that we're communicating out to others. So this can help with raising awareness through different campaign approaches. Knowledge about risk and protective factors can be shared and can help inform policy and resource development. And it can also be used to communicate with the general public or with state legislators. Having information related to rates and patterns of the use of lethal means, for instance, can help inform mitigation and safety practices. Describing geographical and subpopulation differences in risk or resilience can be helpful, as well as understanding the circumstances surrounding deaths by suicide and serious attempts. That can all help inform where and how to drive our resources for different interventions. I think a really key piece to this that we want to be attending to is looking at trends and where there might be health disparities. So for example, we know that lesbian, gay, bisexual, transgender, and questioning youth, as well as Black youth, have increased risk of suicide attempts and suicide death. So we did want to do an additional look into that and share some resources that are available. Through data from the Youth Risk Behavior Survey, we know that LGBTQ youth are almost 5 times as likely to have attempted suicide compared to heterosexual youth. And A great resource, if you're not familiar with it, that I mentioned before, is the TREVOR project, and that focuses specifically on the needs of our LGBTQ youth. It offers some resources, research, education, as well as crisis supports for youth themselves. The TREVOR project conducts an annual survey of LGBTQ youth and their mental health needs, and that really elevates the concern of health disparities among LGBTQ youth. So there is a link to the most recent survey from 2020 that's provided here, as well as you can access some of the prior ones. I think they just did this was their third annual survey. And what that survey shows us, as I noted, is that LGBTQ youth have much higher rates of having seriously considered attempting suicide compared to heterosexual or cisgender youth. It also shows that they want access to safe and affirming mental health care, but they face barriers in accessing that care. And those barriers are related to affordability, concern related to parental or caregiver permission to access care, and even finding a provider who's knowledgeable, safe, and affirming, which we know is really essential in lowering the risk related to suicide. So one example from our state, our Pride Center of Vermont has a Vermont Diversity Health Project, which is an effort to connect LGBTQ youth with affirming healthcare providers, including mental health providers. So it's a project that actually invites providers to apply, be reviewed, and then added to a list in a database where youth and others can look up to find providers for their particular healthcare needs and in their region. Again, I just wanted to make sure folks were aware of the crisis supports that are available for youth through the TREVOR project, and so that link is also provided here. And so now I'm going to turn it over to Barri, who's going to talk more specifically about health disparities related to Black youth.
So traditionally, the African American Black community suicide rate is lower than other ethnicities or racial groups. There has been an increasing trend in completions and ideation within the youth. Specifically, over the past decade, the increases in the suicide death rate for Black youth has seen the rate rise from 2.55 to 4.82 per 100,000. We know that Black youth under 13 years are twice as likely to die by suicide, and when compared by sex, Black males are 5 to 11 years more likely to die by suicide compared to their white peers. The suicide death rate among Black youth has been found to be increasing faster than any other racial or ethnic youth group. And then in regards to the Youth Risk Behavioral Survey, that study's findings indicated that suicide attempts rose by 73% between 1991 and 2017 for Black adolescents, while injury by attempts rose by 122% for Black adolescent boys. As a result of this information, there has been an emergency task force on Black suicide and mental health created in Congress, and a call to action to increase the attention on mental health and suicide among Black youth. Though the reasons aren't fully understood and there's lots of contributing theories, it's apparent that suicide has somehow increasingly become an option of how these youth reconcile their emotional and psychological pain. So we're going to shift perspective a bit to the state lenses, and I'm going to represent, obviously, West Virginia. I've been in the position of directing West Virginia suicide prevention programs for over 10 years, and I just want to acknowledge those are our capital steps, and this work is more about honoring individuals who we've lost, those who have lost their loved ones or survivors of suicide loss, and those who struggle to stay alive and have that lived experience. That's the work that I do and the people that I work for. Suicides in West Virginia, I can name the number of lives lost year after year for the last 10, but I also know a lot of their names, and I know the people they left behind. So I think it's important to acknowledge that one is too many. One is somebody, someone. It's their husband, daughter, son, father, grandfather, friend, just their loved one. So those are shoes, again, that we put on the capital step that represented lives lost in 2018. And so I also, when I talk about data, I refer to lives lost because they are representing the life. But it is important to acknowledge data in regards to the significance and prevalence of the suicides, and to inform stakeholders, et cetera. So this is a chart of the rate per 100,000 in West Virginia. And comparison to the United States, you'll see we had a higher rate in 2018. Traditionally, we've always had a higher rate. Though the rate has decreased, we're still higher than the United States. But it's important to acknowledge that for the first time in over 2 decades, we have seen a decrease in our lives lost from 2018 to 2019. So hopefully that continues to trend, and some of the interventions and initiatives that we're trying to employ are actually being successful. As was previously mentioned, it's important to look at methods to drive prevention initiatives or environmental strategies in regards to intervention. And you will see that in West Virginia, firearms are a very prevalent mechanism of suicidal completions. We are higher than the national percentage. And one of the hats I wear, in addition to director, is I do sit on those mentioned child fatality and domestic violence fatality review teams. And most often with firearms, it's an accessibility issue. Our firearms in West Virginia are immediately accessible. There's not a lot of storage regarding firearms, and therefore it does increase the possibility of suicides by firearms. I think that being said, a lot of our strategies are to disseminate firearm locks, disseminate information regarding firearms and suicide deaths to a wide array of individuals, such as, firearm ranges, firearm dealers, police academies, National Guard, just lots of places where we can increase the education regarding that immediate accessibility to means. Because again, in those fatality reviews, almost 99.9% of the time, that firearm was in a recliner or under a bed, on top of the gun cabinet, or on top of a refrigerator. So that's a significant strategy that we employ in our state in regards to reducing suicidal completions. So a little bit about the layout of the land in suicide prevention in West Virginia. Prevent Suicide West Virginia is the actual statewide prevention program. We're funded through the Bureau for Behavioral Health and Public Health. And we also have programs underneath that umbrella. The goal or initiative of this program is to provide for education, awareness, gatekeeper trainings, also obviously incorporate evidence-based practices and increase protective measures, universal prevention, messages of hope and help. We do work to improve identification, referral, and engagement for at-risk individuals through a wide array of mechanisms. We provide largely part of our services are technical assistance and consultation services for, I would say, prevention, intervention, and unfortunately sometimes postvention systems of care. We work towards building organizations' capacities for coordinated care. We know it's, suicide prevention is the responsibility of everyone and within the capability of anyone. So we work to increase that capacity within our communities. And then finally, our overarching goal is to produce a statewide infrastructure for culturally competent, caring, comprehensive, sustainable suicide prevention, intervention, and postvention systems of care. So in regard to funding, it has increased over the years in terms of pockets in which you can receive funding. But I just think in this moment, we do need to acknowledge that a lot of the funding for youth suicide prevention comes from Garrett Lee Smith Memorial funding. And Garrett Lee Smith was the son of Senator Gordon and Sharon Smith, and he lost his life to suicide in 2003. So I wanted to honor that. As a result of that unfortunate death, there was increased attention to youth suicides, and a lot of the funding that occurs in our country for youth suicide comes from Garrett Lee Smith Memorial grants. West Virginia has been the recipient in cohort 2, 5, 9, and 14 As previously mentioned, we do have a little bit of funding that comes from the Bureau for Behavioral Health and Public Health. And I think it's important also to acknowledge that in between cohorts, the Bureau for Behavioral Health and Public Health provided for sustainability of our youth suicide prevention program. It's also important to note that we do not have dedicated state line item funding for suicide prevention, and we hope to work to gain that at some time in the future. Additionally, the Bureau for Behavioral Health funds 6 regional youth service centers. They were established as a community-based treatment and service center of excellence for youth and their families with substance misuse or mental health issues. And at those centers, we do have housed under the Garrett Lee Smith Memorial Grant an intervention specialist per region. And they're charged with providing for increased implementation of evidence-based programs in their region, such as youth trainings, as well as improving the identification, referral, and engagement for the youth. That could be via screening, direct referral as they become a point of contact within the region, as well as building the capacity to see vulnerable subpopulations. And then one of their key components is to provide for follow-up care to individuals that present to emergency departments or discharge from inpatient psychiatric facilities. And that care really entails ensuring there's safety planning, ensuring and establishing whether there's barriers to treatment, accessibility, and just supportive follow-up, kind of check in, make sure things are okay, and do whatever needs to be done to ensure that there's access to appropriate treatment. Zero suicide really guides a lot of our goals and initiatives in our state. For those of you that don't know, it is it's really a commitment, not necessarily a program, but it's a set of tools and strategies, a concept and practice to ensure that we don't continue to lose individuals to suicide in systems of care, essentially via either health or behavioral health. There are 7 components. I'm going to briefly touch on them just so you're familiarized. I know there's going to be further discussion of zero suicide implementation to follow me. But the lead component is really having a leadership-driven group, advisory group. It really needs to include individuals with lived experience and individuals of survivors of suicide loss. And then training everyone in competent, confident, and caring practices regarding suicidal ideation, attempts, completions, having a way to identify those individuals who are at risk among the people who are receiving care, engaging, ensuring that they have a suicide care management plan or pathway of care, using evidence-based, effective treatment for suicidality, and that unfortunately is not common practice, definitely across our state. I'll be honest, we're working on implementing some of those things, but people take for granted that you're taught that in graduate school, and that's just a common equipped practice, and it's just not the case. So we really need to focus on appropriate treatment, not simply treatment. And then finally, as previously mentioned as part of the national strategy, is applying that data-driven quality improvement. So measuring what we're doing, determining whether it's effective, and then making adjustments accordingly. All right, so this is the suicide care pathway, and it came upon really thinking about zero suicide, and this is the overarching goal of what our grant is trying to do, what our program's trying to do, and it is our main initiative. And basically, it is to embed this practice into every agency that intersects with individuals. So wouldn't it be wonderful if anytime you went to youth services or your primary care physician or a mental health center that you're screened for suicide, and if necessary, there's an assessment conducted, and if necessary, and as a result of the assessment, there's risk formulation as to whether or not you're at a heightened risk for suicide attempt or completion. And then as a result, we do safety planning. Safety planning should be a universal practice. It's within the capability of anyone to do. And because we know that in a perfect world, that referral is not immediate. Oftentimes there's going to be, quite a few days before you might be engaged in effective early treatment. So if you had a safety plan to keep you safe in the interim, I think it would be ideal. And then finally, follow-up. Follow-up's a fairly new concept in the last, 5 years or so, but it's so simple and effective. There's been a lot of research regarding that something as simple as sending a postcard can negate a subsequent suicide attempt. And the way I look at follow-up and think about it is we are starting to do it a lot more extensively in the medical field. For example, I have 3 teenage boys. Okay, so we frequent MedExpress a lot, or we have as they've grown up, because they are rough and rowdy. And every time we go, I get a phone call within 24 to 48 hours. Hey, how is so-and-so, and how's that ear infection going? Or how is that twisted ankle? Why can't we do that for someone who's made an attempt on their life? I think we just owe people that practice and that level of care. So idealistically, this is what we all should be doing and how we all could change the trajectory of suicide in our state and nation. So a little bit about what we offer, and I do have pictures. So for those of you listening to the recording, I'll try to describe them a bit. But we offer a wide array of trainings, and that's important. And I realize we need to go beyond trainings and do intervention and other components. However, in a state such as West Virginia, I've had the privilege to train tens of thousands of people. And in that, you do create connections and you do increase referral mechanisms and people do know where to go. So I'm a firm believer that you can't do this work. You have to do it outside where it's occurring. Some of the trainings we offer, I'll acknowledge, our Safe Talk, Applied Suicide Intervention Skills Training, Youth Mental Health First Aid. We did develop a locally recognized Respond React through COVID because a lot of the evidence-based trainings weren't allowed to be delivered virtually. And then obviously safety planning is huge priority for us, QPR. And then we oftentimes tailor trainings to people's requests. So, but the picture is a picture of a bunch of individuals in masks because we did assist during COVID. We actually did, I think, 11 or 12. But we were socially distanced and we still did it. And it was important that we showed up because, people were struggling. And though the preliminary account of lives lost said that in 2020 there was a decrease in suicides, we at that time just didn't know. And so we wanted to ensure that we had ready, willing, and able caregivers blanketed across our state able to help with intervention. We also offer a wide array of trainings for youth, but most specifically signs of suicide through MindWise. We were able to deliver that virtually over the course of this past year. And I gave you a glimpse of Cohort 9, which was a 5-year grant, but just to show the capacity and number of trainings that were delivered with 6 individuals. We do our trainings small classroom size. We want to ensure that there's safety, and there's a couple of things to consider there in regards to ensuring there's a mechanism of referral in place. If we go to a region, we ensure like the comprehensives are capable of receiving referrals if need be. So there's a partnership. We don't do trainings, for example, on Fridays because we don't want to identify somebody and not be able to follow up. So and part of that, I'm going to attribute that 96,244, and they may be duplicated youth, so I'll acknowledge that because we might have gone to a school more than once. But it's because we do have some legislation in West Virginia that requires that all secondary school students, middle and high school, have to have a conversation regarding suicide prevention. So that helped exponentially propel the work that we were doing previously. So in regards to increasing the awareness, again, I'm one that, we meet people where they are and to reduce stigma. And so I coined it making it okay to say, because I feel like the more that we have the word suicide in public places, the more I wear it on a t-shirt, the more I'm allowing opportunities to talk about suicide. I'm showing that it's safe to have a meaningful conversation with me and it's okay to say it. So the 2 pictures I'll describe, one is at the high school SSAC basketball tournaments. It's a big deal in West Virginia. It's very heavily attended. And so every year we set a booth up there. This year we weren't allowed to set up a booth. And we just allow people to come and have a conversation about mental health or suicide. We disseminate lots of information. And I can say I've had hundreds, if not thousands of conversations. You know, it's 4 days for 2 weeks from 10 a.m. to 10 p.m., but it allows it to be okay to say suicide. So this year, additionally, every team got a Prevent Suicide West Virginia towel with the National Lifeline number on it. And every single team was super okay and proud to take a picture for us. So there was no shunning. It made suicide to the point where it wasn't shameful, and it was allowed to be discussed. And I can't tell you just how incredibly meaningful that is. Another thing that we do, or another opportunity that came last year at the tournaments before they got shut down because of COVID, was we had a gentleman who traveled about an hour back home and said, you know, I don't know how to talk to my kids about suicide. Is it okay if we have a conversation with you? And he went and got his 2 teenage sons and came, and we had a beautiful conversation about how it's going to be okay to reach out to help and how dad would be okay. And it's just really powerful when you show up and what can happen. And so the other picture on the right is actually September National Suicide Prevention Day of 2020. And we wore masks when we were inside, but we literally blew up our love balls and our You Matter signs and stood at the corner while people were driving into work and just let them know that, you know, you matter and that we care. And we passed out cards regarding you survived 100% of your hardest days. And I'll show those in a minute. But I think a lot of what we do in this field and this work is about people. It's about making connections, and it's just about showing up. So we just keep showing up. Except when we can't. So COVID did hinder a lot of the way that we traditionally have done outreach. And that picture, there's a picture on the bottom of myself and my partner in crime to fight against suicide. And we went around and disseminated those You Matter cards throughout, you know, various places, like, as well as other suicide prevention educational materials, such as the Lifeline card and, you know, just pamphlets regarding, you know, warning or risk factors and protective factors. But we sent flyers out and carry-out orders. We had multiple restaurants that we reached out to that were more than happy to provide a mental health flyer, food pantries, and those blessing boxes. So we just kept carrying on. And finally, hashtag keep going. That's exactly what we, and I think the rest of the world did. But we did make some adjustments to the way that we did prevention and presentations. So in regards to virtual presentations, and I'm pretty much a stickler on this one, we asked for the cameras to be on because there's nothing harder than being able to read individuals' emotions or what you might evoke in an individual at a black screen. So one of our training requirements is camera on. We do partner up, so one of us will monitor chat while the other one is presenting the information to ensure, you know, if somebody reaches out, because my partner in crime is also a survivor of suicide loss, so she has a unique perspective in regards to how she can be supportive if people are coming to attend thinking they're going to, you know, go through some kind of survivor of suicide loss training. And then as well, we acknowledge the resources prior to training. So I always acknowledge the Lifeline, the crisis text line, you know, some ways that they can get help if they drop off and something happens. In regards to trainings for youth, we did transition to the MindWise virtual training. Again, camera on, small groups. There needs to be a trusted adult to monitor chat. There needs to be acknowledgement of resources as well as a referral mechanism prior to the training. So that was super important. And best practice is to have a mental health professional from the school on the actual meeting, as well as some other ways to get help. Oftentimes there's a notification, obviously, to parents that will be occurring as well. And then finally, again, we did it anyway. We did continue to hold in-person trainings. Everyone had to wear a mask. We followed the CDC guidelines. So for example, I might have rented a ballroom that would hold 200 people for 30, but no one was renting ballrooms, so it wasn't very costly. And then rather than sharing markers or posters, we would print off individual sheets for everybody or use apps so that we did not cross-contaminate things. So I'm going to talk really briefly about some of our collaborations. The beauty about being in West Virginia is that we are a small state. And as you're around the table for a while, you tend to have the privilege to work with everybody else. And I truly do believe that together we are stronger. And so I'm going to briefly touch on each of these agencies, but there's a wide array of others. But the Suicide Prevention Council for Prevention of Suicide is actually the first program that was started in West Virginia prior to any Garrett Lee Smith Memorial grants. And then it transferred to me and Prevent Suicide West Virginia, I'd say about 6 or 7 years ago, but they still serve as our advisory board. So they're comprised of stakeholders from a large group of agencies in the state as well as the community, and we still meet on a quarterly basis. TREVOR is represented by my friend I refer to as my partner in crime, Survivor Suicide Loss Group. We do a lot of work training together, as well as the next step, which is kind of what designs and markets. And it was mentioned before, words matter. We're very careful with the language and the materials that we disseminate. Marshall University has had previously a Garrett Lee Smith Memorial Grant, but recently we've partnered with them to provide for Cognito for their medical school, School of Nursing, School of Pharmacy, and School of Social Work. So hopefully to increase the capacity of the ability of those individuals to deliver effective suicide care. West Virginia Department of Education, lots of consultation, technical assistance, cross collaboration with creating materials, and just, ensuring we have an incredible partnership amongst various and multiple agencies within the Department of Ed. The Center for Excellence in Disabilities, again, a lot of TA and consultation. During COVID, we did a lot of monthly meetings with that group. Additionally, I've had the privilege to train all of their individuals in ASSIST. So expanded school-based mental health, I sat on that board, and we've done, again, the protocol policy development. SciMed is a behavioral health management company that has a all-inclusive contract with Department of Corrections in West Virginia. So we collaborate them with TA and consultation, as well as training, attempt reports, as well as losses. So they do share some of that information with us. Some of these the only other two I definitely want to highlight in lieu of time is First Choice Health Systems answers our National Suicide Prevention Lifeline number, as well as Hope and Help WV, and a wide array of mental health, support warm lines. We partner very directly with them, ensuring that everyone that answers that lifeline number is trained in ASSIST. We do also ongoing training with them, as well as, I know it's going to be discussed more extensively in a moment, but the 988 initiative, we're working to increase our state infrastructure to respond to that. And then finally, the Governor's Challenge. I know at least 35 states are doing that, but it's working to development statewide suicide prevention focus specific to military veterans and their family members. So that's a really big collaborative initiative within our state. And finally, we do everything we do with the support and the voice of, like I mentioned in the beginning, the people we serve. So those are the people we've lost, those who have lost their loved ones, and those who struggle to stay every day. And some of the things we've done, one of those you'll see, we're in the mall with You Matter, Your Life Matters to Me, and just have conversations at a Starbucks. We did, during COVID, do a buddy check social hour where people could come in. the provision I would give there is that we ensured it wasn't, just focused on one individual, but it was like we had a guided shared activity to ensure that everybody was safe, that everybody had the opportunity to share. And then, something as simple as street chalk can make a difference in a day. And finally, I want to say with that again, focus groups, and I hate to call them that because we really tend to have conversations, maybe with a guided agenda, but really just sitting down and talking to people and meeting them where they are. I think that's the way that we're going to continue to reach people, increase the connectedness, and ensure that, we reduce the number of lives lost.
Okay, I'm going to be moving into speaking about Vermont, our data and our strategies for impacting suicide prevention. So to start with, Vermont is consistently ranked one of the first or second healthiest places to live in the United States. However, our suicide rate is 35% higher than the national average. And some of the reasons in terms of looking at our population that we believe this is tied to is we do have high rates of binge drinking. We have high rates of firearm ownership and easy access and purchase of firearms. We're also a very rural population. We're the second most rural in the state. We eked out West Virginia just by one. They're the third most rural state. And we do skew older. Our population is 20% age 65 and over. And we know older folks have been impacted by suicidal ideation and suicide deaths disproportionately. And another factor with Vermont, we're overwhelmingly white at 94.2%. And that is another, in terms of race and ethnicity, it impacts our population suicide rate. And so not only are we 35% higher than the national average, we've been increasing disproportionately. So although the US rate is going up, Vermont's rate is going up even more over time. And this is something that we're absolutely keeping an eye on and trying to figure out what's behind it. So if you go to the next slide, one of the things I'm going to talk about in terms of how Vermont looks at the data, and I want to acknowledge you've seen a lot of data in this presentation so far. I'm about to go through some additional data points, but I want to give you a feel for why we look at these data points and how you might look for them and what you could do with them. And so we talk about in Vermont the data in a few different ways. We talk about mortality, so that is those lives lost by suicide. We also look at morbidity, meaning, and that's the technical term in our health department, that's really about folks who have attempted or needed emergency care due to harming themselves. So that's an indication that required medical intervention, but did not end up in someone losing their life. So we're going to look at some of that data as well. And then a little bit more upstream, we're going to show you some youth risk behavior survey data. And that's asking people, how are you feeling? How much ideation do you have? Which, it's one thing to measure how many lives lost, and then it's another measurement on how hopeless is our population, how distressed is our population, and how can we impact that. And so this slide mirrors what Barri showed you about West Virginia, in that although we have most attempts for self-harm that require medical care are poisonings, overwhelmingly so with a suicide attempt. However, that is a very small amount of folks, only 11% actually die by suicide through that method. In Vermont, the vast majority of people dying by suicide are by firearm at 55%. And so we know this is about, as Barri said, access. And I think one of the things I'll name, we agree with everything Barri said, that I think part of the conversation needs to be making sure people are aware that suicide is often an impulsive act. And it is something that you may be just going through a life crisis versus someone who might have been, chronically depressed. And there's an assumption by people that someone had to be chronically depressed, and that is just not true. And so the impulsivity, it's one thing to have an impulsive thought, it's another to act on it. And having access in that moment is a major factor in suicide death. So one of the things we're working on in partnership with the Department of Health is, how do you store firearms? How do you talk to your friends about maybe you're going through a difficult time. Could you hold on to my firearm for a period of time? And there's ways to do that through policy. There's also ways to do that through community awareness, education, and just connection with making sure that you would help your neighbor and have transparent conversations about means. So those are some of the conversations we're having in Vermont, and we need to have a lot more of them. I also just want to note, because I always say this, my background is I used to assess children and youth for suicide risk. And I had many parents who would answer the question when I asked them, do you have a firearm in your home? They said, yes, but it's in a gun safe and my children don't know the code. And then they would leave the room. I would ask that youth, hey, do you know the code? The parents would come back and I'd say 5479. So I think it's really important to understand that youth are real, they can, teenagers, they can figure anything out. And so I think making sure you're updating that code all the time and taking extra care to keep that secure. So in terms of self-harm in Vermont, we're actually seeing a very disturbing trend. And so this is overall, especially since 2020. So one of the things Vermont looked at, we did look at suicide deaths in 2020. I think there was a lot of concern that would rise due to COVID. Well, that did not happen in Vermont, but what we have seen is increased attempts in self-harm. So you'll see starting in 2020, that rate going up, particularly in females, although it has gone up a bit in males as well. I will show you specifically for youth, it is an incredibly disturbing trend. And so this is a chart that's showing you middle school aged students, which is 11 to 13 years, and high school aged students, 14 to 18. And as you'll see, there's been a trend upward. And in fact, when you turn the curve from 2020 to 2021, that increase has become stark, and it is something we're actively talking about. And I think one of the things that interest us with COVID, overall visits to the emergency room have gone down because people were less likely or trying to stay away from the emergency room. However, that has not been the case for the self-harm attempts. And we definitely are trying to do everything we can to reach that population and make sure they're getting other resources versus attempting self-harm. And we'll talk a little bit about some of those strategies going forward. So this is where we're going to talk about some of the upstream data, and this is where we get a feel for how our youth population is doing prior to necessarily an attempt or any other metric. So this is the Youth Risk Behavior Survey, and we would encourage folks to be taking a look at this data in your own areas, because it's asking about serious thoughts about killing yourself, if you've made a plan, and if you've attempted. And it also breaks it out for gay and lesbian youth or unsure, as well as bisexual and heterosexual. And so that gives a real clear indication of how different populations are doing. And we have seen a very disparate impact of students who identify as LGBTQ in comparison to their non-LGBTQ youth. And so this is one place where we can go to get a feel for how things are going for different populations before they reach our emergency departments. And so again, this is something that would be really good to look into if you haven't already in your state. Another indication from the Youth Risk Behavior Survey, this is talking about whether or not the youth has felt sad or hopeless in the last 2 weeks, if they've made a suicide plan in the past year, purposely hurt themselves without wanting to die, or attempted suicide. And of course, we're watching that blue line at the top increase over time with that feeling sad and hopeless, as well as there's some increases in the purposely hurt self without wanting to die. And lastly, the attempts have unfortunately increased through 2019. So again, this gives us an indication that not only are youth having more ideation, they're also acting on that ideation in a greater rate over time. One of my favorite things to talk about, and I know Barri and Laurel too, is, there's issues about what the needs are and how much distress there is out there. There's also protective factors. And we're looking to measure those as well so that we can see if what we're doing is increasing them. And so the Youth Risk Behavior Survey also takes a look at that. And it takes a look while really being transparent about the impact of gender identity and sexual orientation on those protective factors. And so what you'll see here is information about whether or not the youth feels like they matter to people in their community. If they're eating dinner at home with at least one parent, or if they have at least one adult in the school whom they can talk to. And those are incredibly important. A sense of belonging in particular can be an extreme protective factor. I know with youth that I've used to work with, they would constantly say they feel like they're the only one who feels that way. They feel very alone, and they wouldn't want to burden anyone with their story, nor do they feel like anyone would understand. And so having those conversations and making sure they understand people do care about you, and let's not only have that conversation, we're going to say it out loud to you. I think sometimes professionals are afraid to say that out loud because you're trying to keep clinical boundaries, and that's why having more community connection and empowering youth to help youth can really help to build that sense of connection and belonging. One of the strategies we're using to reach youth is the crisis text line. And so in Vermont, we say text the letters VT to 741-741, but it is a national resource. And we've had over 2,000 texting conversations in Vermont from youth. And I say youth because the majority of them are. So we're looking at the age breakouts for those accessing the service. There are older Vermonters, but the majority are under the age of 24. And what we find particularly interesting about the users of our text line is that the majority also identify as LGBTQ. And we've tracked this to our Outright Vermont group, which is our advocacy and resource group for youth identifying as LGBTQ. They've promoted this line, all over the place, and it's worked. And not only that, but the folks and youth who are using it say that it feels helpful and welcoming, which is big for a system that's struggled sometimes to reach that population. And I would also note we have more non-white texters than we do in our Vermont population. So we're reaching more folks who identify as Black, Latinx, and Indigenous or Native American than we do in our normal Vermont population, which has been very encouraging as well, where it feels like it's a place where people can text and feel heard and welcomed. And also they walk away. I actually read, sometimes they write little notes when they about their success stories from the text line, and you can read them. It's anonymous, but we can see that piece. And it's been overwhelmingly positive, where people just want someone to talk to, and they want to talk to them right that minute. They don't want to wait for a therapy appointment in 3 weeks. They want to talk right then. And the top conversations that, in terms of what the needs are when they text, are anxiety and stress, depression and sadness, followed by relationships, loneliness, and then suicidality is about 28% of texters. Another source of data for Vermont, particularly around strengths and protective factors, is the Child and Adolescent Needs and Strengths tool. It's called the CANS. And one of the data points we like to highlight when it comes to the CANS is we ask about community connection, and we ask it in terms of, is there someone in your community who cares about you? Is there someone you would go to in your community that you trust? In Vermont, 56% of students identified that they do not have that sense of community connection. And 48% of students reported having little to no optimism or future orientation. And those are two key factors in terms of protecting against suicide. Another piece of data that we look at is resiliency, and 46% of students were identified as needing to build resiliency, feeling that they didn't have a way to face challenges in their lives and needed help to build that skill. And those are data points that we are looking at directly so that we can increase. And so it's been very nice to have a tool that's actually measuring those strengths and protective factors and not just needs. In terms of Vermont strategies, we are moving forward those with Lifeline. I'll give you a quick synopsis on that on the next slide. We're also, like Barri said, using zero suicide. So I will not revisit that entire conversation, but we just want to echo the point about follow-up. And I will note that in Vermont, part of our plan for increasing follow-up is to engage our peer and persons with lived experience community, because we know for caring contacts, having someone who's been through it can be particularly adept at having that conversation. So that's something we're looking at right now. And then a few other evidence-based approaches are counseling on access to lethal means, that's CALM, and then CAMS, Collaborative Assessment and Management of Suicidality. We track outcomes on those tools, and I'll show you a brief slide that looks at that, as well as gatekeeper trainings across settings, and that includes schools, communities. We've done gatekeeper trainings for law enforcement so that anyone can help anyone out there in the community. And if you're interested in zero suicide and you have no idea where to start, we've included a link here that'll tell you how to do an organizational self-assessment. And that's a great place to go to say, what do we even have? And it's quite possible you have some pieces of it already. So it would identify for you, here's where you're doing pretty well. Here's some things that you would want to build on if you wanted to use this model. 988 as a strategy. Hopefully folks have heard that the National Suicide Prevention Lifeline is transitioning to a 3-digit number starting in July 2022. And we just want to highlight that Vermont is working towards that. And if you go to the next slide, we can just show you that we had not done very well with the Lifeline in the past. We were actually at 0% call response a few years ago. We've now moved ourselves up to 36%. What that means is we have people in Vermont answering the line, and then they can refer people to Vermont resources, which is part of the intention with the Lifeline model. And so that's going to be a big part of our strategy in terms of we don't have a ton of capacity for mental health professionals in Vermont. Not everyone can get an appointment the next day. So we're really trying to beef up, if you need something right now, who can you call? In terms of additional strategies for suicide prevention in Vermont, we did have a Quechee Bridge mitigation project, and that's looking at, do you have hotspots in your area where suicide deaths are happening at a high rate? We had one of those in a gorge, and we put a project together to create a fence that was very difficult to climb, and it has the impact has been less suicides, actually no suicides in that area since that time. The rest of this slide I won't go through in detail, but if you look through it, you'll find resources for each of these icons on the internet. So I would let you search amongst yourselves. One of the other points we would like to make is there's a real need for tracking outcomes of your programs. As someone who goes through the legislature trying to talk about what we're doing as a state, these visuals matter. And so this visual is actually of a program called You Matter. This is a youth-focused program that is training youth to help other youth. It's talking about you matter because you yourself matter, and building resiliency and understanding of your own self-worth, but also you matter because you might be able to help someone else. So this is outcomes based on participants in that group, and we have used these outcomes to promote the program and sustain funding. Another successful evidence-based practice in Vermont has been CAMS, the Collaborative Assessment and Management of Suicidality. What was somewhat astounding to me, although it shouldn't be as someone who used to do this work, is that just because you're a therapist or have a clinical background doesn't mean you're comfortable assessing suicide or even asking someone about suicide. And when we surveyed providers about this, they did indicate they were not comfortable or confident in their ability to assess. CAMS training changed that for them. So this is an outcome about the providers in Vermont who took CAMS training and how much more confident they felt not only to assess, but to treat patients and clients who had suicidality who came into their care. So we promote this program, and we also have utilized these outcomes to sustain it. Lastly, in terms of resources in Vermont, we did create a health card. It's not just a card. We have wallet cards, there's posters, we had magnets for a little while, which those are somewhat expensive to maintain, but it has all of the resources on it. And so therefore, if you are someone who identifies as LGBTQ and you're looking for that specific resource, or a veteran, or you prefer text, everything's on there. And we've been working to promote those and get them out for free and have them printed for free by any stakeholder who might want them. This is simply a resource slide, so please utilize it and take a look at some of this will take you to where we got some of our data, as well as, you can note some of the information about the TREVOR project and the Suicide Prevention Resource Center. Finally, you will see after this slide, there are additional resource slides that you can access that we won't have time to go through today, and we encourage you to take a look. Thank you all for participating in the webinar today. If you have any questions about West Virginia, Vermont, or suicide prevention efforts in general, please do not hesitate to reach out to Barri, Laurel, or myself. Thanks very much.